Conversations, brought to you by the Australian College of Rural and Remote Medicine. Here we will talk with dermatology experts and rural doctors about ways to care for patients in rural communities. Sit back and enjoy the conversation.
Hi, this is Kambiz, Digital Health Project Officer at the ACREM. Just to introduce myself, I am a physician from overseas, and also I have a PhD in digital health from the University of Western Australia. Today I am interviewing Dr. John Bingley regarding the use of telehealth in wound care management. John is a vascular surgeon and provides his advice and support to the ACREM Tele-Derm service. He is a graduate of the University of Queensland Medical School. John began working at the Mater Hospital in Brisbane in 2004, where he has worked as Director of Surgery for several years. He has helped the Mater vascular scenes to grow and develop its reputation for a compassionate, reliable, high-quality service. John completed a Master of Medical Science and PhD researching acute vascular injury, just to name a few of his achievements. Dr. John Bingley, welcome to this interview with ACREM.
Thank you.
Wound care has always been a major issue in clinical practice. Problems such as diabetic foot, bed sores, and other kinds of wounds, particularly in palliative care, are always a challenge to be treated. Considering the difficulty of face-to-face visit in many cases makes telehealth an important and attractive modality in wound management. There have been lots of pieces of evidence that express the effectiveness of telehealth in wound management. Dr. John Bingley, what's your opinion about the use of telehealth in wound management?
So, thanks for inviting me along, and John is fine, just so you know. I think telehealth is, as you've described, underused. I think for anywhere, but in particular in Australia with the great distances, telehealth is a perfect modality for helping manage wound care. Can I say that I think that there are a couple of things with wound care which are assumptions which are wrong and we should correct. One is that an old wound is just a long-standing acute wound and needs to be treated like an acute wound. It's a very different pathology, and I'm happy to talk about that. But without that understanding, it won't heal. And the other is, and this comes up with the palliative care setting in particular, is joining together with the patient and the family and the carers, driven by the patient. You need to have a decision about what you're trying to achieve. Sorry, I know this isn't quite getting to the telehealth part of it, and I will, but if the doctor thinks that they're aiming to heal a wound on a patient who's dying and is palliative, and would be better having a wound that is treated in a way that allows dressings to be changed without pain or with minimum pain, and the dying process to be done with dignity, the approach is very different. And that requires a bit of discussion. It's not given to a short consultation. That said, telehealth, and in particular those sort of patients, the bedridden, the palliative, they're not in a great position to be travelling distances, sitting in waiting rooms, ambulances on the way, transit centres on the way back, to be seen to have a wound review, especially if their treating team is somewhere else. So telehealth does a couple of things. It saves an inordinately unpleasant journey for a relatively short consultation. It also disconnects the patient from their environment and their carers. And the person seeing them, be it a doctor or whomever, doesn't have that easy communication the way telehealth allows you to. So telehealth doesn't just provide convenience, but it actually provides an educative process both ways. me at this end can see the circumstance and the people and the way a team communicates, and the team at the other end and the patient are in a position in their comfortable environment to ask questions. And so there's an education process both ways. So I think telehealth's perfect for this.
Thank you very much. And what kind of wounds would you think are more manageable through a telemedicine consultation? There is a contradictory between specialists that some kind of wounds are more manageable.
Yeah. With rare exception,
Yep.
probably every wound.
Yep.
Okay, I'll be a little bit radical. Because telehealth, the difficulty we all appreciate is how do you see a wound on a sacrum on a television? Well, or on a computer screen. Well, you take a photo of it beforehand, right? And use that as part of the communication. So we get caught up in this idea that it's one discrete event that we've got control of at the consultant end, at the expense of everybody else. Mm-hmm. And I think a little bit of it, sorry about this, is a little bit about power at our end, and I think we could get over that to everybody's benefit. Between verbal and photographic communication, or even email communication, and then the telehealth at the time, I think that's a perfect setup. The difficulty comes with the expertise perhaps in examining an arterial circulation. But to be honest, you can usually pick the arterial wounds without having to feel the pulses. Not always, don't get me wrong, but for the vast majority you can, and thankfully they're the minority of wounds. So the idea of having to have a complete and thorough vascular examination to be able to make a decision about how to manage a wound, I think is an overcall. Yeah.
Could you please tell me about your personal experience of telewound care?
So I came to this in a very interesting way. And sorry, I should just add one more one more problem to the conversation before. The problem becomes around confidentiality and consent. Now, those acknowledged and planned for, telehealth doesn't become a problem. But you can't just go sending photographs into the internet without permission. And it needs to be secure. But that's what telehealth understands too. And so I don't believe that's a block, although it's a mental block sometimes. My experience in telehealth came about an interesting way. I was at a loose end, to be honest. I'd been the director of surgery at the Mater for a period of years, not too many, or maybe too many, but whatever, I stopped. And so I had a bit of time in my week, and I realised increasingly that my understanding of chronic wounds, the wounds that are hard to heal, was imperfect, and I had good conversations and good communication with wound care nurses. And there was a team at QUT here in Brisbane who were part of the Collaborative Research Centre in Wound Management Innovation, based at QUT at Kelvin Grove. And so they invited me to be part of their clinic, which wasn't a big clinic, but it was a multidisciplinary team. Occupational therapists, nurses, now a doctor, podiatry just down the road, or just down the corridor. So it was actually a very good service. And the legacy vehicle from that CRC organisation was something called Wound Innovations. It was a business that was set up to try to manage just this, including a lot of telehealth. And in fact, I would say probably in the end about 95% of the work was telehealth. It's too hard to get patients in. We realised that early. Based here in Spring Hill with just that team. Wound care nurse practitioners, regular nurses, occupational therapy, podiatry, and myself as a clinician. And that, so we did a lot of telehealth, and this must be, I don't know, 7 or 8 years ago now to start, to be honest. And we were doing cases from Brisbane in Kununurra, in northwest Western Australia, and in Cape York and Western Queensland, but also in nursing homes in Brisbane, because it was important, and COVID has just made clear how good telehealth is, right, to the medical and to the wider community. So that was pre-COVID, but I don't know where Wound Innovations is up to now. I think it's based in South Australia, but I understand the work still goes on, and it's a very important service.
Thank you very much.
And I still do telehealth.
Yep.
Yeah, from my private practice and from our public clinic at the Mater.
Based on what we see on the ACRIM Tele-Derm website, however, we receive only a few requests for tele-wound care each year, which seems much lower than expectations. What is your idea about that?
I agree with it. Absolutely agree. I think there is a series of reasons for that. One is awareness, always an issue. A second is a sense that chronic wounds can bring about, which is almost a sense of despair, that this wound can't get better. The poor person is living with it. They're not really suffering too much. That's we don't know what to do, but nobody does. That's okay. I've asked a lot of people. Nothing works. So I think trying to hold onto hope is an important thing, and that's very difficult for chronic disease oftentimes, for the patient and for the carers all across the board, including the healthcare practitioners. I don't know that I could say in Australia that the logistics and the technology is not available. I believe it is, although not everybody's comfortable with it. In nursing homes, that's been, in my experience so far, general practitioners and their setups are often perfect for Tele-Derm, especially in the country, or for telehealth. Nursing homes, it's a little bit more ad hoc, and I think that speaks to the difficulty it is of working in that space. They are very busy, as I would understand it, terribly understaffed, and trying to time something when you've got to look after 30 people is really difficult. So I think there's some logistics in the nursing homes. I think in the community with general practitioners, I find that almost seamless. Yeah.
Thank you. Fantastic. What are your recommendations to ACRIM for providing telewound care and helping rural and remote doctors on this matter?
So, one is, I think the Tele-Derm has been a fantastic innovation, and Jim Muir and Dan Kennedy, way before me, have done such a wonderful job in providing that service. The reason Jim and Dan and I get together is often around the very chronic wounds, the ones that are too hard, right? As I said at the beginning, I think there is some misunderstandings that a chronic wound is just an old acute wound and needs to be managed with the next best dressing. So I think there's an educational component. But we do this with Tele-Derm. We do the online webinars, 2 or 3 times a year that I'm involved with. And often it's speaking to the same principles of, and honestly relatively simple principles that distinguish the chronic wound, and when well addressed, I think those principles serve healing very well. But I think that's an educational thing. I see wounds every week. That's not the case for somebody in a general practice who has 110,000 other things to consider as well. And this is one that's been perhaps going for a long time, and they don't feel nobody feels expert in this. Can I briefly say about there's this tension between expertise and being part of a multidisciplinary team. And we don't serve ourselves well always as doctors in this, because we are historically and often continue to want to be the expert. I believe that chronic wound care is a perfect example of the requirement for multidisciplinary input, and that the expertise lies in the team, not in any one individual. There will be different sets of experience and different skill sets for how to manage, but there's no one practitioner who can do all of this. not the clinic nurse or the clinic doctor or the occupational therapist or the wound care nurse practitioner or the vascular surgeon. We often need, or the podiatrist. We do need to share that experience somehow. That makes sometimes telehealth a little harder, but with a little bit of planning and good communication, not everybody has to be in the room at the one time, but it is possible to keep people informed.
Thank you. And my next question is, would you classify Tele-Derm care as a part of wound care management?
So, this is now somebody who is absolutely not an expert in burns. I rarely see burns.
Yep.
It just doesn't come up.
Yep.
Burns tend not to be a vascular surgeon's domain.
Yep.
That said, inherently, I don't think the principles of burns healing are any different from the principles of wound healing in any other. There is an injury and a mechanism for injury that has happened, and now the body's physiology is doing what it does. So if the principles of wound healing are approached appropriately, I can imagine that Tele-Derm burns would be perfect. Again, it's a confidence and an experience, but that's why health works so well, because your experience can be just there in, the face on the computer. I don't know that most burns would need to be seen by the burn specialist in the room face to face for adequate management. That would surprise me. It wouldn't surprise me that some feel that's the case, but I think that's a little bit about control rather than patient care. We need to be mindful of that. That might be controversial, but there you go.
Thank you. It's just my interest to know what are the most common causes of wounds
that I see?
That you see?
Just
I guess, for example, diabetes related wounds are more common, or bed sores, something related to aged care,
yeah,
or wounds because of trauma.
Yeah. So it's a great question, because I can describe to you my practice as a vascular surgeon. So we don't often see pressure sores, although because I have an interest in wound care, I do get referred pressure sores. Sometimes in patients who have quadriplegia or paraplegia, for instance, where my practice doesn't have, and our hospital doesn't have the capacity to look after spinal injury patients. But that says something a little bit about the despair and the desire for looking for help. So those wounds aside, most of my work is lower limb wounds. But the reason the lower limb comes to vascular surgery is essentially because there's a question about the arterial inflow and the venous and lymphatic outflow, all of which are very good questions to understand and to help manage a patient. The healing of those wounds doesn't differ particularly from the healing of a wound anywhere else in the body, from any other cause. Let's exclude malignancies, okay? Malignancies don't heal with dressings. They need proper malignancy-related care. So take those away, and you can sometimes overlook a wound, forgetting that malignancy is a possibility. So biopsy is important. The wounds that I see fall into two categories. In our clinics, our wound clinics have been divided into just this. So there are the patients whose wound is primarily related to neuropathy and pressure on the foot, and for the vast majority that's diabetes-related peripheral neuropathy, but there are other causes for peripheral neuropathy also seen in that clinic. And that clinic, in fact, is running now with my colleague at the MARA, Danny Hagley, and the registrar team, and the endocrinology team, and the podiatry team, and the wound care nursing team. That's the multidisciplinary team at that clinic, and it's honestly the vascular surgeon's role is to exclude arterial inflow insufficiency because diabetes is a major atheroma risk. Thankfully, for the large part, ischemia is not the issue. The issue is pressure relief. And it's a principle for a bed sore or for a pressure wound on a foot. If you don't relieve the pressure, the wound can't heal. It's just re-traumatising. So pressure relief becomes central. The wound care part, and so we've put all those patients in that particular clinic because there's the endocrinology and podiatry built around the diabetic patient, but around pressure relief that is essential to that group. The group I see are the other patients who have lower limb wounds and chronic wounds, and their wounds for the most part are related to gravity-related edema and its effects. So rarely arterial inflow is the issue, rarely. Almost always venous, but in particular lymphatic outflow is the issue. So there are some patients who have venous insufficiency, deep venous thrombosis related or varicose veins related. Well, you can do something about the varicose veins, but honestly you don't have to oftentimes, you just have to manage the fluid in the leg. And then there's the lymphatic related, the extracellular fluid that pools, and most of those patients don't have lymphatic damage. In fact, most of this group of patients I'm describing don't have venous damage or lymphatic damage. What they have is immobility. So they have gravity, pooling fluid in their legs, and an inability to shift that fluid back up to the heart to recirculate because they can't mobilise. They don't have the calf and foot muscle pump, or if they do, they mobilise in such a way that that pump doesn't work. And so you need to find a way around that because you're not going to turn these people into athletes. That's unkind to them. You need to acknowledge the fact that that's a contributor and then park that and say, well, what else can we do? We can use gravity, elevate the leg when possible, and use compression to help reduce and maintain reduction of the edema in the leg. They're the key. I have a patient in the hospital at the moment. She's had a wound on and off for 20 years. It's terribly painful because the fluid that comes out burns the skin like a chemical burn. It's the exudate, but it's got a higher pH than normal fluid or than the skin likes, and so they get this chemical burn. Now, I haven't focused any treatment on her wound. All we've done in the last 2 weeks is get the fluid out of her leg. She had the best night's sleep she's ever had 2 nights ago. The wound is smaller, not because we're doing anything to the wound, but because we're managing the fluid and protecting the skin. So it's that, and that's by elevation and compression. They're what's left. There are some patients who are retaining extra fluid in their body because they have heart failure or kidney failure or liver failure or they've got hypoproteinemia. Well, in those circumstances, there's a role for diuresis. But if it's gravity-related fluid, not body-wide retention of fluid, then it's gravity-related treatment, not body-wide diuresis is the management. Yeah. I think I'm off track here a little, but that's okay, because those are some of the important issues.
Oh, yes.
So that's the group of patients I see, and often elderly or infirm or variously abled, and oftentimes, and this is something that can't be gauged by looking at a photograph of a wound, are oftentimes in a role at home that doesn't allow them to rest and put their foot up. They live alone. They're a carer for their spouse. A number of patients I have want to go up and sit in the nursing home at their spouse's bedside every day, and that's their role in life. And they don't actually care too much about themselves or their ulcer, as long as whatever we're doing doesn't stop them doing what's important to them. That also needs to be acknowledged. A little bit like the circumstance in palliative situation. What is the aim of what we're trying to achieve for you? And the patient knows that. That's not us to tell them. If we keep pursuing healing of a wound and take this patient away from the love of their life, I don't think we've served them well.
Excellent. Thank you very much.
That's
John.
okay.
And thank you for accepting our request for this interview. The ACREM Tele-Derm is funded by the Australian government and is available to all Australian rural doctors working in MMM3 to 7 and also all ACREM members. Should you have a case you wish to submit for advice, go to the discussion sections of the service. If you want to contact us, you can either email the digital health team at ehealth@acrem.org.au or call us on 1800 223 226.